Okay. Well, out of respect for people's time, I'm going to go ahead and get started. Well, welcome everybody. I want to thank you for joining us today. Let me introduce myself. I'm Nina Kim. I'm one of the doctors here at the Madison Clinic, and I also lead a team that includes Jordan, Lindsay, and Tala here in the clinic. We are part of the Center for AIDS Research, or CFAR, that helps connect people to research opportunities, and we're really excited to host today's webinar. As you may or may not know, we have a growing body of science that shows that one of the antibiotics we use to treat sexually transmitted infections, doxycycline, can be used strategically to prevent these infections, and this is called DoxyPep. So our clinic and the University of Washington was one of the sites for the DoxyPep trial, and these results got published this year. And I'm pleased to introduce our panelists, Dr. Connie Celum, Dr. Julie Dombrowski, Dr. Rodney Perkins, and Dr. Chase Cannon, who are part of the DoxyPep research team here at UW. So they can share the science and answer questions, your questions about what this means for you. So just note that we are recording this so that we can make this available to those who couldn't make it. And please put your questions as you think of them in the chat, or when the speakers are finished, feel free to raise your hand using the reaction button, or just unmute and ask your question. And yeah, we can get started.
Hi, Nina. Are you, can you allow us to share our screens?
Yeah, you are co-host, so you can share here.
Do you want to continue? Yes. Oh, good. It worked. Well, my name is Connie Celum, and maybe just my thought is it might be good, just since it's a small enough group and hopefully to break the ice a little bit, just to ask people to introduce themselves. That's okay. You don't have to, but I'll start and try to give you a really thumbnail sketch of kind of why I was involved in this research, and then ask others from the investigators team to introduce themselves too. So I'm an old physician who grew up was training in San Francisco when HIV was really at its worst in the 80s, and really committed myself to trying to do something about STI and HIV prevention. And I've, spent 2 decades where it felt like all we could do is ask people to change their behavior. And then we finally started seeing some successes with other approaches like HIV PrEP, and realizing the potential powerful impact of treatment on prevention. And then have always had a strong interest in STIs as well as HIV. And so as we started seeing the need for STI interventions, decided this would be something that would be important to try to study. So thank you for the invitation. And if anyone on the call was involved in the DoxyPep study, directly or indirectly, I just really want to thank you too. This was a challenging study to implement at the time, and we couldn't have done it without the support of the Madison Clinic and patients there and in the sexual health clinic. So, Julie, do you want to introduce yourself? And then
sure. Hi, I'm
Rodney.
Great. Hi, I'm Julie Dombrowski. I am a physician here at UW, and I am a doctor in the Madison Clinic. I worked on this study, the DoxyPep study, in the sexual health clinic. You'll hear a bit more about that. And I was very excited about this because we haven't had something new in STI prevention for a very, very long time. We've had all sorts of exciting advances in HIV, like Connie just alluded to, but haven't had anything in STIs for a while. So that's me, and I'll pass it over to Chase.
Hello, I'm Chase Cannon. I am also a doctor at the Madison Clinic, and I am a late comer to the DoxyPep team. Was not there for the initial planning sessions, but sort of helped out on the tail end, and we're looking at some of the behavioral data, so things that people said that they did in terms of behaviors and different actions related to DoxyPep. That should be hopefully coming up soon.
Rodney, do you wanna?
Hi, my name is Rodney. I'm a nurse by training. I actually became a part of the project as part of my dissertation. And so I basically come from, I think, a lot of prevention work. I used to work in Washington, D.C. at Whitman Walker's Gibbons Health and Wellness Clinic. And so my dissertation was sort of nested in the project. So I worked as a research coordinator on this project as well, and actually participated in some of the interviews and some of the qualitative data that we'll share tonight. And my project really looked at alternatives, looking at benefits of DoxyPep beyond the mitigation of STIs, looking more around the pleasure and the benefits of sort of like the quality of life of using this particular intervention.
Right. So maybe I'll just go back to the slides, and what we tried to do, and I'll try to speak simply and clearly, but if anything isn't clear, please stop. It's a small enough group, feel comfortable asking questions as we go. And I think Rodney has a few slides too to share after I share mine about the study, what we learned, and expanding on the qualitative findings. But we want this to be interactive, so do not feel shy about saying what. Okay. So first, why did we do this? And these are two slides that I show to remind myself and others that we are seeing a lot of STIs, both globally on the left, and I'm sure that's an underestimate because there's not a lot of STI diagnostic testing happening in places like Africa. And I've done PrEP trials there where 1 out of 3 women on PrEP have gonorrhea and chlamydia. So take those numbers with a grain of salt. But in the US, we have better surveillance, and we've seen for the past 7-8 years a steady increase in STIs, particularly gonorrhea and syphilis, and really disturbingly congenital syphilis, which can be quite devastating. And not, people have different likelihoods of getting an STI. In general, the US data suggests that it's younger people, men who have sex with men and trans women, and pregnant people, and racial ethnic minorities. And so one of the issues is just like, what can we do differently to try to respond to these increasing numbers over what's almost a decade? The group that we focused on for the DoxyPep study was men who have sex with men, because if you take the data that we have reported from clinics on the upper left for gonorrhea and chlamydia, or nationally for syphilis, in the maroon bars it shows men who have sex with men, and it's not that everyone has the same likelihood of getting STIs. And so the rates have been higher among men who have sex with men and trans women, probably in part because we now have these really powerful interventions like PrEP and treatment, which you can get translates to U equals U if you're virally suppressed. And so condom use has changed. STIs are common in the sexual networks that people are in, and it's leading to these disproportionate burden among men who have sex with men. So one of the things that we started thinking about several years ago in designing this study is that maybe antibiotics could be used for prevention as well as treatment. And the antibiotic we focused on is doxycycline, because we had first of all, and most importantly, that we knew it was would work against chlamydia, syphilis, and possibly against gonorrhea, as well as it was used for decades, and we knew its safety and tolerability profile, and it's pretty inexpensive. We knew that it may not work in gonorrhea because a quarter to a fifth of gonococcal isolates, when you do antimicrobial resistance testing, is resistant to the tetracycline class, of which doxycycline is in. And we didn't, and that's for treatment, but we didn't know, there may still be benefit for using it for prevention, because you might need less of it, or if you catch it early, doxy may still have some impact on preventing GC, even if it wouldn't be expected to fully treat it. So what I'll summarize in the next slides is that the three most recent clinical trials that were done to see whether or not it would reduce bacterial infections, and also tell you a little bit about what we learned about its impact on antimicrobial or antibiotic resistance in STIs and other bacteria. So I put in this slide for high-level finding, and what we did, and I'll show you this in other ways, but just to make sure this comes through really clearly, is we did a study where we recruited men who have sex with men and trans women who are either on PrEP or living with HIV in 4 clinics, 2 in San Francisco, 2 in Seattle, and in Seattle it was Madison Clinic and the Sexual Health Clinic, of the MSM and trans women who had an STI in the past year, and then they got randomized to either get DoxyPep or no DoxyPep. And the main thing that we were looking at is whether or not we could see a reduction in bacterial STIs, gonorrhea, chlamydia, and syphilis per quarter, and had an independent group of people looking at the data. We were blinded as we went, truly didn't know if it was working until we were asked by this data safety monitoring board to stop the control arm, because it was working so well with a 2/3 reduction that they thought it was not ethical to have a control arm. These findings were in the context of men telling us, and trans women telling us, that they had taken about 4 doses per month, and that 85% of their condomless sex acts were covered by doxy. It was safe and well tolerated and very acceptable. In a graphic form, this is showing you kind of the study design that if in the 2/3 who were randomized to DoxyPep, they were given a supply of doxycycline and told to take a single dose, 200 milligrams, within 72 hours, and earlier was better, after a day when they had condomless sex acts, and not to take more than a dose per day. We had planned to enroll a total of 780 across the 2 cohorts of those living with HIV and those on PrEP. And because we were stopped early, we didn't meet that target. And again, the inclusion criteria were being assigned male sex at birth, living with HIV or on PrEP, having a STI in the past 12 months, reporting condomless sex with at least one male partner in the past 12 months. And then we saw people as part of clinical practice at both Madison Clinic and Sexual Health Clinic with 3-site GC and chlamydia testing, and then syphilis serologies. And this shows you the data that we had at the time in May 2022, when the Data Safety Monitoring Board took their first real deep look at the efficacy and said, you should stop it. And at that point, we had about 500 participants, roughly 2/3 were on PrEP, and about 1/3 were living with HIV, a little younger population in the PrEP cohort than those living with HIV, and had about 2/3 were white, 8% were Black, 11% were Asian Pacific Islander, and 30% were Hispanic or Latinx. A majority reported that they're like a large majority, almost 90% reported that their sex partners were male only. 2/3 approximately reported we had evidence that they had been diagnosed with gonorrhea in the last year, about 60% chlamydia and 20% syphilis. This was by and large a group who, based on what they told us, had were very sexually active and had decided that they weren't going to use condoms. 90% reported only condomless sex at enrollment, and an average of 9 partners. And this, in a graphic form, shows you what I said in the word form, that we found about a 2/3 reduction, in both the cohort of MSM and trans women on PrEP, as well as those living with HIV. And we saw this shows the rates in each of those cohorts, with blue for gonorrhea, orange for chlamydia, green for syphilis, and in black, those who had more than one STI. And this is per quarter. So when you design a study like this, you have to make an estimate of what you think you'll see based on the data you have locally. And we thought we would see about 10% per quarter in the control arm and the standard of care arm, and it was 30, a little over 30%. So STIs were very common in the control arm, and that's why the study found its results, its efficacy early, and was able to stop early. We also broke it down by different sites of where gonorrhea and chlamydia happened, and we had pretty little pretty low prevalence of gonorrhea in urethra. Most of it was either in the pharynx or rectum, and that was also true for chlamydia. But it appeared to work well at all those sites, although again, we didn't have a lot of urethral gonorrhea or chlamydia. We had lower rates of syphilis, and again, this was in the context of following people for about 9 months on average before the study was stopped. But even though the numbers were lower, the significance was still quite high. So on the right shows you that we found about a 50%, little over 50% reduction in gonorrhea, and about an 80% reduction in chlamydia and syphilis. It was really well tolerated. We found, we did lab monitoring, looking at people's white blood count and their liver enzymes, and found only 1 abnormality. So very safe. Had a few people report diarrhea or headaches. A couple of % of people didn't tolerate it well. Mainly it was GI issues. We looked because there's some data, like in mice, that if you use doxycycline in animals, which is where it's used a lot for weight gain, that maybe you would see that in humans. We didn't see it. There are 2 other studies, and I'll summarize those in a minute. One from France, one from Kenya, that also found very high safety and tolerability. We looked at antimicrobial resistance. We looked at it both for Staph aureus and gonorrhea. And with staph, about almost half of people were colonized with staph, as you know, either on your skin or in your nares, in your nose. We found that those in the DoxyPep arm were less likely to stay colonized, about a 14% reduction. And among those who still had it at 12 months, they had about an 8% increase in doxycycline resistance. So there was kind of, it's maybe better to not be colonized with staph in terms of getting other serious infections from Staph aureus, but there was a little signal that there's an increase in doxy resistance. The staph that gives us the biggest headache to treat is a form called methicillin resistant Staph aureus, or MRSA. We only saw that at about 6%, and it did not become more resistant to doxycycline. Gonorrhea was challenging because you have to grow it to find out what it's resistant to. And we found a small increase in the DoxyPep arm in those who had high level resistance, but it was really based on small numbers. The French study found a similar finding. So maybe doxy won't work as well if someone's exposed to gonorrhea that already has tetracycline resistance. I'm gonna just mention this briefly because I think Rodney will come back to this in a moment, but we did a qualitative sub-study because we really wanted to hear from the users. We had 44 participants from San Francisco and Seattle interviewed. We tried to oversample minorities and persons living with HIV. And I think what we learned from these in-depth interviews is the value that MSM and trans women placed on having peace of mind and sexual pleasure, that what they told us was that it gave them a sense of confidence and being empowered and responsible for their health and doing something for the health of the community, that it didn't really change their behavior, but it gave them peace of mind and intimacy and confidence, and that most were aware of this issue of possible impact on antimicrobial resistance, but it wasn't a barrier. So this is a busy slide, but the point I'm just trying to make is that this study we did in Seattle and San Francisco is one of now 4 studies. There had been a smaller study done in France that was published a few years ago that showed about a 47% reduction, and people were interested, but they didn't feel like it was strong enough to really change practice. So that's why we did, in part, why we did the DoxyPep study, and I've told you the results. The DoxyVax study was just presented this past year, and they found, similar to us, a very high reduction in chlamydia and syphilis and about a 50% reduction in gonorrhea. And unfortunately, a study that was done by some of our colleagues in Kenya in a population of women assigned, female assigned birth in Western Kenya who are on HIV PrEP, that in spite of a pretty high baseline number of gonorrhea and chlamydia infections and a high incidence, it was a flat study. And a lot of that appears to be due to adherence. So that we're at the stage now that there hopefully is going to be another study in younger women in the US that's just getting organized. But guidelines have been developed both locally and by the Centers for Disease Control based on the findings in MSM and trans women. We're recommending it based on STI history and sexual partners, and really encouraging us to do shared decision-making to help people be aware of the data and to make decisions for themselves. I was just at a meeting yesterday with a colleague from San Francisco, and they've been really implementing it at a large scale. The Strut Clinic, which is operated by the San Francisco AIDS Foundation, now has about 2,800 people on DoxyPep. Since it's a sexual health clinic and most are on PrEP, they've been pretty liberal about recommending it. And they have data now that suggests reductions in, these data were from the summer. Now with another 1,000 persons and more time on DoxyPep, they're really seeing some significant declines in chlamydia and syphilis. So far, it's not so clear with gonorrhea. The other clinic in San Francisco that's been doing this at scale is called the San Francisco City Clinic, similar to our sexual health clinic. And they've had also, now they have over 1,000 people on DoxyPep. Those who are taking it tend to be those who've had an STI in the prior year and those who've had more partners. And they're not seeing any disparities by race, ethnicity, or age. They're finding similar doses reported per month, and that people are being somewhat selective in who they're using it with, not with all partners. The CDC guidelines draft guidelines came out for public comment last in October and will be finalized soon. And they gave it an A1 grade, which is like the top level of evidence, saying that basically it's a strong endorsement for the quality of the evidence and suggesting that it should be used for basically the population that we enrolled in the DoxyPep study, those who've had a bacterial STI in the past 12 months, and they're saying we need more evidence to understand whether it works for those assigned female sex at birth. So I'll just wrap up here and just say, I think we need new STI prevention tools. It's really helpful that all 3 studies that were done in MSM, that's typo, trans women, showed evidence. And we have evidence now both for those on PrEP and those living with HIV. Want to be really clear, we're not trying to endorse this for everyone. We're trying to really find that sweet spot between those who had STIs, those who may have it be more likely to get them in the near future. We're not recommending this as a lifetime intervention, and people's behaviors and circumstances change. So this needs to be reassessed periodically, and it should be part of an integrated package of with PrEP and HIV care. We need to learn more about antimicrobial resistance, and locally we're planning and seeking funding for an implementation study that would allow us to obtain more information about resistance and the gut microbiome. And we're concerned that we want to make sure that we do our best to try to make sure that people can access this, those who need it the most. And we've seen in the past decade that we've not done as good as many of us would like in terms of it doing equitable access to PrEP. So let's see if we can do better here. And Nina asked me to mention STI vaccines. Ultimately, we'd love to have STI vaccines. And there's the one that's furthest along is several trials of Bexsero, which is a specific meningococcal B vaccine, and the meningococcus and gonococcus share outer membrane proteins. And so we're awaiting more trial results in the next couple of years, but stay tuned for that. And there are also efforts to develop a gonorrhea-specific vaccine. The syphilis and chlamydia vaccines are at earlier stages and probably looking at a much longer time period before those will be available. And then I just want to end by thanking all the people who had a hand in coming to these results, including those who participated in the trial, either at Madison Clinic and Sexual Health Clinic. So I'm going to stop sharing and just open it up to questions, and then I think we should have Rodney share his results. Questions? Does that make sense?
Thanks, Connie. That was really great.
Thank you, Lindsay. While people are thinking of questions, Rodney, do you want to come on camera and off mute and share your qualitative insights?
So basically, kind of gave you like a little preview to the qualitative work that we did, but really, our qualitative piece kind of has like a little 2-part to a certain degree. Kind of looked at really patients' experiences, and as I said, I kind of incorporated sort of my dissertation work into that. And so here's some kind of like some of the key topics that we kind of looked at with regards to the work that we did. Really just wanting to kind of get the attitudes about DoxyPep kind of from the individual as well as their partners and their peers. Really beliefs about DoxyPep, the risk benefits and the effectiveness and the necessity. And then one of the components I'll add into there was that benefit. They really try to now, as we talk about these preventative interventions, really looking at, really talking about the risk as well as the benefits, and pleasure being one of those benefits for individuals. And then looking at the lived experience, kind of the meaning of the use and adherence and side effects, and then the impact on sexual practice as well as STI prevention, and then the impact on quality of life, as well as supporting the context around sexual and STI prevention, kind of looking at the historical attitudes about that, and then sort of attitudes around ARTs and PrEP disclosure. So our methods, basically, a summary, just we did one-to-one interviews via Zoom with the population. Some interviews later, as we got through COVID, were able to be done in person, but the majority of the interviews were done via Zoom. And participants were compensated for the interview. They were compensated $50, not $25 in that regard. This just is a little snapshot of the participants that we interviewed. Gives you a little bit of look at the age difference, as well as racial difference and ethnicity and HIV status, as well as the clinic that they were enrolled from, as well as the use. So it gives you, we get quite a diverse group that we interviewed. And so I'm not going to read each quote, but I just give you like sort of like the overview of each, which the accessibility was perceived as effective. Although, as Connie said, DoxyPep really wasn't used for to prevent, doxycycline is not used to prevent gonorrhea. The population still felt that it was quite effective in preventing gonorrhea for them, and they felt pretty good about the effectiveness of DoxyPep. They also thought it was pretty easy to use. The study drug was a 200 milligram tablet, so some of them were concerned about the size of it. They thought it was a little big, but I think that was like the only thing, but it wasn't really a significant barrier. Most used to routinely taking medication. They were used to the visual cues and proximity, and then the liberal time window, but basically when you could take it was also a component that they kind of talked about as well. Again, around side effects, most common was GI issues, loose stool, stomach upset, and a lot of people sort of like, curb when they take it, when they took the medication with regards to sexual encounters, and when they could kind of ward off some of these types of side effects. But overall, they felt it was manageable. Most found it workarounds with regards to timing of doses when taking it with food, whether it helped them or made things better. Few reported side effects as a barrier to adherence in taking it. Again, around acceptability is concern for long-term side effects or long-term effects of taking antibiotics. The individuals had some concern around antibiotic resistance. I felt that those who really was concerned about their microbiome and so forth really monitored how often they actually took the drug. But again, some of them had some concerns, and I think that kind of like gauged how often they took Doxy, whereas those who weren't so concerned kind of didn't really make that as an issue and didn't really control their use of the drug. As far as partners, what I thought was pretty interesting is that, a lot of the communication around PrEP use was no longer really having these conversations around disclosure. So it was more about, I'm on PrEP, and for the most part, people knew what that meant. So that meant, I go to the clinic to get tested, and I'm HIV negative. So it really didn't have to kind of go into this long conversation. But the unique part about Doxy is that people who were in the study were able to say, I'm on Doxy as well. And then it struck up a conversation, and it really allowed them to really teach, their sexual partners about Doxy, and sparked a little interest in that regard. So it was really became another communication piece around, this is what I'm doing to protect myself, and kind of giving the other person the feeling that, to be a little bit more at ease. And this was especially true for those who were living with HIV, where, again, it presented this position that I'm doing a little bit extra to make myself and my partner safe. Then the impact, Connie kind of alluded to this, which is around the mental health aspect, around, mental health and quality of life, which it gave people peace of mind. So most of the participants really talked about, if they hooked up with someone, it made them feel a little bit better with regards to that experience, or they didn't kind of find themselves beating themselves up, wondering if they've gotten an STI from this particular person. So it really was this kind of like, I felt reassured that I'm taking care of myself. And I really think that it, again, passed on to partners that they felt a little bit more reassured that this is what this person is doing to protect themselves. As far as sense of control, again, it really puts the control of you preventing STIs for yourself. One of the things I thought was pretty unique is some of the individuals who we recruited for the study came to the study with some practices that they developed while they were on PrEP. So some people had moved to not using protection as much, and the ways they've offset that was by testing. So although using PrEP required you to get tested every 3 months, in all 3 sites and getting your blood drawn, most people were testing monthly with throat and rectal swabs because they weren't using protection. And that was their way of trying to catch an STI early. And then using Doxy really allowed them to not have to test so often. So I thought that was a really interesting component when, again, you learn what people have done to keep themselves safe. DoxyPep became another way to protect themselves without needing to go to the clinic to get tested. And I think that became a very common practice for a lot of the participants. Again, around mental health, kind of supporting partner and community. Most people thought if more people were aware of DoxyPep, this would basically increase usage within the community and therefore decrease STIs within networks. And I thought that was a really important component, especially again, for those who were living with HIV. They felt like, there's something else that people are doing and it could communicate that would prevent STIs and make people feel a little bit more comfortable. Again, around STI prevention and practice, well, half reported really no change. And the first thought for most people is that this new intervention is going to cause people to have a whole lot of sex. And I felt like, well, people are having more sex, but for the most part, I thought most people will have participated in the study kind of like test the limits of DoxyPep, sort of like had a little bit more sex, but then it ultimately falling back to their normal routine, normal pattern. So did people have more sex in the study? I think so. But for the most part, it really was no major change for people's sexual activity. Again, it just added another tool to their toolkit in regards to prevention. And then, as I think I've already alluded to some of this already, which is around condomless sex, an increase in number of partners, the willingness to engage in other types of sex that they may have been concerned about, as well as the frequency of sex. So all those things were something that DoxyPep offered the participants. These are some of the key findings, which was around high acceptability, which they believed to be effective, easy to use, well tolerated. They perceived benefit that offset concerns around drug resistance, acceptability to partners, as far as positive impact on mental health and quality of life, pretty much with peace of mind, sense of control, supportive of own partner and community health, increased self-awareness, and then the varied impact on sexual and STI prevention practices. There was no change for half of the population. More partners, condomless sex, types of sex frequency was all things that happened for most participants. Increased communication with partners was a biggie to me, and not always used for oral sex. So that was one of the components where some particular individuals didn't think that taking DoxyPep after oral sex was necessary. So I think that's like one of those teaching gaps with regards to like as this continues to roll out. And I think that is my last slide that I had to share.
That's great. Thank you so much, Rodney. There have been a few questions that have come through. So one question is about if you, maybe Julie or Chase could talk about the antibiotic resistance piece. The question is this dose low enough that it is impossible, or is it based on the type of antibiotic? Which is a great question.
Sure. So antibiotic resistance can happen with any antibiotic, including doxycycline. And the dose that is used for DoxyPep is basically a double version of the dose we usually use when we treat chlamydia or syphilis or other infections. So antibiotic resistance could develop, and that's what we're trying to study and see if it happens. We haven't seen signs of that yet, but it's still pretty early and we haven't followed people over a longer period of time. So something that we want to study more. Chase, anything you want to add to that or clarify?
No, I think that's correct. We just, it's possible, but we don't know that it will happen. Never been proven for chlamydia or syphilis, and so we are hopeful that won't be the case, but never want to say never because we don't know everything, and then we will be proven wrong, and it's been recorded.
Yeah, that is a really important point, though, that there's not any resistance right now in chlamydia or in syphilis. So the main places we're looking for resistance are either in gonorrhea, where there is some, or in other bacteria in the body like staph and strep that are normally on our skin. And if we have doxycycline around, those bacteria could potentially become resistant.
And the other question that we got was, is there a way to get notified by further trials, especially ones involving women? I work in an outreach organization focused on street-based sex workers, and this is very relevant to that population.
Yeah, I think the study in women that is being considered will be happening through something called the Adolescent Trials Network, and where they already have sites around the country, and Seattle is not a site, but we can, I think it's still good, even if we can't recruit participants here, to be aware. It's probably realistically going to take a year to get the protocol approved and funding and all the details worked out, but unlikely that it'll be enrolling in Seattle.
And then the next question was, I also have run into providers not knowing about DoxyPep. And the question is, are there resources that can be provided to clinics around Seattle so that this information is available?
Yeah, do you want, I don't know, Chase or Julie, do you want to share your thoughts? I mean, they are available. I think it's trying to figure out ways to increase provider awareness of where to look and address their concerns if they have them about prescribing it.
Yeah, Rodney, were you going to say something?
Yeah, I like the NCSD's command center for DoxyPep. So it's a nice launch pad for information to provide for providers to look at, some of the research around DoxyPep, as well as give you some guidance on tips on implementation.
Yeah, I agree. And then here locally in Seattle, we have a healthcare collaborative that includes representatives from all of the different health systems and community health clinics. And we've done, webinars for them and tried to make sure that they know that there are guidelines for King County and for Seattle. They're available publicly on the King County website, and making sure that they have sort of champions in their system that can then go to the providers that work in those clinics and get the message out. I think that's a challenge. How much does the message actually penetrate and get into the folks that need it, who may not be in one of those clinics? So if somebody's private practice or something, it may be a little bit harder, but yeah, Rodney's right. The national sort of STD group that is putting on webinars is trying to get the message out to everybody as much as they can. And we're all individually doing a lot of talks in Seattle and everywhere. So hopefully the message will get out to people eventually.
Connie, Go ahead, Connie.
No, I was just saying I put the link in the chat. I mean, I think yesterday I was at this Ryan White meeting where it was interesting to hear from providers around the country. And I think that Seattle is more like the rest of the country and less like San Francisco in terms of the numbers of people who are getting on DoxyPep. But a lot of people are in the early stages of figuring out the messaging and the operational aspects of trying to do this.
Yeah, I was curious. I mean, I was very interested to hear Rodney's qualitative data, but I'm also thinking in the back of my mind, these are people who participate in the trial. Many of them are already on PrEP. You know, they're in some ways a healthcare seeking group. And whether you're going to explore any qualitative data, looking at people who are just like maybe declined or didn't, you know, are hesitant, or, you know, how do we reach the people who don't necessarily think of themselves at risk? Yeah, any exploratory work around that?
We are planning in this implementation study, which if it's funded would happen in not just San Francisco and Seattle, but also Atlanta, Detroit, Miami, to include qualitative work about reasons for not continuing DoxyPep and also patterns of use. It's always hard to get access to the people who don't join the study. So there probably are other ways of doing that as well, but we will try to expand the qualitative work to people who may start it and just decide quickly that it's not for them. Yeah.
I thought the interesting part of recruitment first was, you know, there were a few people who declined, which I would be curious, although they met qualification, they declined. Then you had those individuals who didn't meet qualification because they didn't have an STI. And so that kind of like created sort of like, you know, population of people who weren't eligible simply because they hadn't had an STI, but they still sort of like were in the networks of the individuals who may have. And so I think those will be interesting components around like what are some of your thoughts with regards to not being able to be a part, but still kind of like along the sideline of being a part of the study because you are a sexual partner of someone else. So I think those will be some interesting stories to hear. I think there were a lot of partners, people who either got into a relationship as they were in the study over the year, who then remained in the study but weren't taking Doxy. Whereas like in California, you had people whose one partner was in the study, but the other partner wasn't. And so then there was different relationship situations where some people who had open relationships. So there was a lot of dynamics that I don't know if we, you know, from a qualitative perspective, I would love to understand those stories and those experiences a little bit more. But I think the other part is that it would be really interesting to see how does this work as you move further east and further south to see what is it like and how does the community respond? Because I felt here people were very engaged. They were very interested. Most of the people who we approached were very happy to be a part of the study. There were very few no's, but like I said, those no's were probably equal to those who basically weren't eligible and wanted to be a part of the study.
Thank you. Well, yeah, we have a little time. Well, maybe time for one more question if folks have one. Or if the speakers had any other additional thoughts they wanted to share about this.
I guess the one question I would have is that this is another community forum. And so I'm curious, how did the individuals who attended hear about this? And what can we do to expand the reach to reach more people? What are some of your insights in regards to what can we do to be able to educate the community of Seattle around DoxyPep?
Yeah, I'm very curious about San Francisco's ability to get 2,800 people on DoxyPep, like within like just months of the study being published. And I'm curious to know if they had a social media campaign or public service message. I mean, it's just that's pretty amazing. Very early adoption and very high uptake.
Yeah, I think they have used social media. I don't know that they've had any public service announcements that I think they've tried to make it very simple and accessible, and they in the San Francisco City Clinic used peer navigators, which they use for PrEP as well, to do some of the initial offering of PrEP. I mean, DoxyPep, sorry.
Yeah, they do have marketing campaigns as well that you know, are maybe a little controversial because the language is more direct and sort of PG-13 or R-rated, if you will. And I think it's been eye-catching enough that it gets people talking, and there are so many different places that people can get DoxyPep in town too. I think that is part of it, but also taking into account that the numbers that they have are basically, it's been almost a year of them having people on DoxyPep. So this started when their guidelines were released last October. So they've had many more months ahead of other places. So not just since the publication, but you know, this is going back to September, October of last year.
And it just, if you would, based on interviews and just interaction, I think momentum was already building. People were very much aware of DoxyPep in San Francisco. It was something that was widely talked about amongst the participants and just the whole community at large. I think in just my dissertation work in travel towards the East Coast, because that's where I kind of focus, it's starting to take on. People are familiar, but I think now that the guidelines and the CDC is kind of like have put some communication, then you're hearing more conversation about it. Because I think one of the places that I went to was just looking at Whitman Walker, that they've now kind of looking at how can we fully upscale this at Whitman Walker. So that's just like a barometer of the East Coast. So just going to Whitman Walker, kind of talking to them, seeing what their plan is, and then the kind of like rollout of this has just been kind of how I test the East Coast.
Great. Well, I just wanted to call attention to folks that we have a little Google Doc link in the chat. If you could just please give us any feedback about this or ways that we can spread the message. We came up with this idea and didn't have as much time to promote it, but we would love to put on more of these opportunities to share the science and spread the message and invite people to ask questions to learn more. So thank you for being here and for your interest. Yeah, have a great evening.
Yeah,
Thank you,
thank you.
speakers, as well.
Thank
Thanks,
you so
everybody.
much.
Thanks, everybody. Bye-bye.
Have a good evening.
Wonderful job.